Well, thanks very much, Huey. That was really a great presentation. I can't really tell you how thrilled I am to be here, not just here today with all of you at this really wonderful meeting. This morning was great to see many patients, and this afternoon it's wonderful to spend time with future colleagues. As a heart surgeon, coming to Houston is kind of like bringing sand to the beach. I mean, it's the mothership of cardiac surgery, and I'm really honored and thrilled to be here. I don't really have any disclosures to make, unfortunately, except to say that I've learned from my colleagues today, but they're great presentations. I learned that I need to update my slides in terms of not only just content, but coolness factor. And I also learned today that, geez, I don't think I want to follow Huey in a presentation again. That was really fabulous. So as we heard, there have been tremendous advances in the management of congenital heart disease. And I think many of those advances have involved heart surgery. And if you look at this graphic, it shows that looking at the decade that you were born, the likelihood of living to be age 18 has significantly improved over the last half of the century. So if you were born around in the decade that I was born and you had transposition of the great arteries, there was about a 1% chance that you'd make it to age 18. If you had tetralogy of Fallot, there was about a 10% chance. Fortunately, due to the great work of our pediatric colleagues, the patients born with congenital heart disease have a much better outlook. I tell my residents, before you do surgery, you really need to have a goal. What is it that you want to accomplish? And certainly over time, the goals in treating patients with congenital heart disease have changed. Initially, we hope to palliate the problem. So we've heard that word a number of times today. And what palliation is surgically is you don't try to fix the anatomic problem. You try to manipulate the physiologic problem. So an example of that is in babies that are born with cyanotic heart disease. Their problem is they have too little blood flow to the pulmonary arteries. So the treatment, the palliative treatment, is to connect a blood vessel from the systemic artery to the pulmonary artery. It doesn't do anything to the anatomy, it fixes the physiology. Reparative surgery is you do an anatomic reconstruction, but you knowingly, understandably, leave lesions behind. And then the ideal is to do a corrective operation, where you fix the lesion anatomically and hopefully don't leave behind any residual lesions. And unfortunately, I think that happens very, very little, despite our best intentions. Again, graphically looking at tetralogy of Fallot, just over time, how the survival has increased over time. If you look at what we do, what the indications are in patients who have congenital heart disease, more and more we're treating previously treated problems, but there still are some patients who show up with a new lesion, a newly diagnosed lesion, or patients that have had no previous interventions for an already known lesion. A number of patients we take care of because of the natural history of the repaired or corrected lesions. And as I think we heard a little bit today, the natural history of patients who've had palliated lesions, which can be, from a surgical point of view, more of a challenge. And just to give you a future coming attraction, there's a whole bunch of patients with congenital heart disease that are now getting to the age where they're going to develop acquired heart disease. And we really don't know what that's going to be. Coronary disease, acquired valvular heart disease, aneurysmal disease. And I think that the cutting and the sewing won't be that much of a problem. It's how to figure out how to do that in patients with all kinds of other issues. So let's look at some new, without previous interventions. So this is a patient I took care of. Somewhere in that crowd, I don't know if you can see her, is a 34-year-old nurse practitioner. She's about to run her 5th marathon. Very fit, has done a great job in the previous 4 marathons. At mile 24, she, out of the blue, collapses. No pulse. She fortunately is running with a colleague, a nurse practitioner, and fortunately collapses in front of a paramedic truck. They put the paddles on her. She's in ventricular fibrillation. Thank God they were able to resuscitate her, get her to a hospital, and they evaluate her. And what they find is that she has an anomalous aortic origin of her left main coronary artery. Do I have a pointer? Is there a pointer anywhere?
Try the mouse.
Oh, there we go. Here we go. Yeah. So this is an axial view of the aorta, and this artery here is the left main coronary artery. It should be originating around here and going behind the pulmonary artery, but in fact, the origin, the ostium, is off of the right sinus of Valsalva, and it traverses through the wall of the aorta, traveling between the aorta and the pulmonary artery. The picture over on my left is a three-dimensional reconstruction of that. This is her front, this is her back, this is the aorta cut in half, radiographically anyway, and the coronary artery comes out from the right sinus of Valsalva, travels within the wall, and again comes out ultimately behind the pulmonary artery. This is an uncommon lesion, but it has been well known as a common cause of sudden death in young athletes. My football practice field at my high school is named after a kid who died at football practice from this lesion. Coronary artery problems, heart surgeons, that's how we make our living. We do a lot of coronary artery surgery. What we've learned is that traditional coronary artery surgery doesn't really work very well with this problem. It's a dynamic problem. If you do a bypass to an artery that has blood flow through it, you get competitive flow, and that bypass will go down. So bypasses to this lesion historically have not worked very well. Techniques like we do for children that have anomalous coronaries from the pulmonary artery, or like we do during an arterial switch operation, just cutting off the ostium and moving that, translocating it to another place, that doesn't work out very well either, just because of the unique anatomy of these arteries. What we did with this woman is we did an unroofing. We opened up the aorta, we found the anomalous ostium, we filleted open the wall of the aorta and reconstructed a new coronary ostium. This is about a year later. We did a CT scan and showed that initially her artery originated from the right sinus and went through posteriorly, but now we've reconstructed a new ostium for the left anterior descending artery and the circumflex. And this, at least radiographically, looks like a corrected lesion. And she's gone back to running marathons and doing very well. We've looked at a bunch of our patients. One of my previous colleagues, Rich Libertson, had a great deal of patients that he followed with this, and with this lesion, over close to 275 patients. And that we're in the process of figuring out which one of those patients would benefit from surgical correction. Valvular heart disease, we heard from Sabrina earlier today. Getting valve replacements, certainly getting mechanical valve replacements, is not a great thing in young patients. You trade one set of issues for another. If you get a tissue valve, the limited durability of those valves will almost certainly guarantee those patients to further interventions or surgery. If they get a mechanical valve, you condemn really those patients to a lifelong need for anticoagulation with warfarin or any other one of the drugs. We now have more and more techniques to reconstruct valves. Ebstein's anomaly, which, as many of you are aware, is you have a dysplastic tricuspid valve that's apically displaced into the right ventricle. You frequently get a very enlarged right atrium and an atrialized portion of the right ventricle. And in severe cases, it causes compression of the left ventricle and can cause patients with it in a full spectrum of ages to have problems. The historic way to deal with this was to do valve replacements, and even with these very complicated appearing dysmorphic valves, we can reconstruct them. This is a cartoon of what's referred to as a cone technique, which removes the valve from its attachments in the right ventricle and can essentially make a funnel-shaped valve and reattach it to the normal annulus of the tricuspid valve. This is an unusual valve problem. Some of the more common congenital problems that we deal with now, bicuspid aortic valve, certainly patients who have leaky or regurgitant aortic valves. We have we've made significant advancements in our ability to reconstruct those valves so that they're competent and at least for about 10-year follow-up, it looks like those valves may be, in fact, very durable. If you look at some of the problems of previously repaired or corrected lesions, we heard a lot today about tetralogy of Fallot, and I'll try to avoid some of the things that we already talked about. Surgeons like to talk about history, preferably about other surgeons, but tetralogy of Fallot, I think, understanding the history of tetralogy of Fallot, there's a lot of lessons that we can learn about congenital heart disease from how we've managed tetralogy of Fallot. Tetralogy of Fallot was first described by this guy, Stenson, who was a cleric in the 17th century. He described what Huey told us about tetralogy of Fallot. It was given a name by Etienne Fallot just before the turn of the last century, and we've come to know it as an anterior displacement of the conal septum, which pulls the aorta forward, results in the creation of a ventricular septal defect. That anterior displacement causes obstruction of the right ventricular outflow tract, and with that you can have hypoplastic development of the pulmonary valve, and with that pressure load, get right ventricular hypertrophy of the right ventricle. The first treatment for this, the Blalock-Taussig shunt, was the idea of it came from Helen Taussig, who was a pediatric cardiologist down at Johns Hopkins. The real genius of the development of the Blalock-Taussig shunt was actually Vivian Thomas. He was the researcher in Dr. Blalock's lab. Although the concept came from Dr. Taussig, it was actually Vivian Thomas who really developed the operation and proved its principle and actually its practice in the laboratory. And Dr. Blalock did it in kids and really unlocked the door into the treatment of congenital heart disease. And that Blalock-Taussig shunt was an anterior thoracotomy, and the subclavian artery was detached and sewn to the pulmonary artery. What was good about it is what's bad about it, is that the blood flow to the pulmonary artery would grow and increase over time and would improve the blood flow to the lungs, but over time proved to be a not a good thing. The reparative option came about after the development of cardiopulmonary bypass in the mid-50s. This is a picture of Dr. John Kirkland, who at that time was at the Mayo Clinic in Minnesota. And he and a few other people around the country and world developed the intracardiac repair as we know it. As Dr. Lin described, the approach on bypass was an incision made through the right ventricle and extending up and through the pulmonary valve annulus. Through that exposure, you could look into the right ventricle, identify the ventricular septal defect, and sew that closed with a patch. Using a second patch, you could then close your right ventriculotomy and increase the dimension of that right ventricular outflow tract. And what was thought at that time to be a very effective long-term cure for tetralogy of Fallot. And in fact, in the early 90s, the group from the Mayo Clinic reported their excellent success over 20 or 30 years in patients born with tetralogy of Fallot. And their conclusion was, in patients who survived, they had excellent long-term survival with tetralogy of Fallot. And that patients who had this transannular patch did have a slightly decreased survival compared to controls, but it was an excellent long-term treatment for it. Part of that operation was that you left the patient with pulmonary regurgitation. And at least what I was taught, this was the standard textbook that I had in pediatric cardiology when I was a fellow in doing pediatric heart surgery. It was pulmonary regurgitation is a benign lesion. It's well tolerated. This is the textbook out of my surgical institution that stated that in patients with tetralogy of Fallot, it's exceedingly rare to need to have a pulmonary valve replacement because of how well tolerated it is. Well, around that time, there were patients that started to show up with real significant problems. Sudden death, patients that had increasing symptoms of heart failure, that had tetralogy of Fallot repair. And the group up in the UK they cataloged demonstrating that, and other groups, that pulmonary regurgitation may not be, and as we've come to learn, really is not a benign lesion. And if you look beyond the graph from the Mayo Clinic, that actually the survival and certainly the symptom-free survival significantly trails off. And that in the last 10 or 15 years, we've gone from the thought that pulmonary valve replacement is exceedingly rare to now, as Huey pointed out, we think we're probably going to need to somehow replace the pulmonary valve of maybe or almost all of these patients. I certainly have replaced a lot of pulmonary valves over the last 10 years, and I think, as Huey pointed out, I think more and more the need for surgical pulmonary valve replacements will be less and less with the innovative technology of the Melody and other transcatheter valves. But with the surgical replacement of pulmonary valves, there has been a demonstration that certainly heart failure class gets better. The number of dysrhythmias is lower, and at least as we can see, that perhaps the long-term survival and following will be better. In the most recent statement from the American Heart Association, there is a set of indications for pulmonary valve replacement, either surgically or now transcatheter. And I would say that this too, the ink isn't even dry on this, and I would say that the indications continue to evolve, and that the the threshold to intervene on patients with pulmonary valve regurgitation after tetralogy of Fallot continues to get better and better. Because if there's nothing else that we've learned is if you wait until people become symptomatic, you probably have waited too long. And I think as our interventions get better, the threshold to use those interventions should become less and less. This is images from literally my last surgical case in Boston. This was a 34-year-old woman who was born with truncus arteriosus type 1. When she was an infant, she had a repair with a patch of her aorta and had a homograph conduit to reconstruct her right ventricular outflow tract. She then, at around the age of 7, had a replacement of that conduit. About 8 years after that, she had a stent placed into her stenotic conduit. She developed endocarditis a few years after that. And when she was in her mid to late teens, I actually took out her aortic root. I replaced her truncal valve and her ascending aorta, reimplanted her coronaries, and I reconstructed her branch pulmonary arteries and right ventricular outflow tract. She represented with shortness of breath and signs of right-sided heart failure. On the axial image, this is her ascending aortic graft, and can appreciate the stenosis of the right pulmonary artery behind the ascending aortic graft. And then on the three-dimensional reconstruction with the aorta digitally removed, you can also appreciate somewhat of a stenosis on the left side. And I imagine Huey's looking at this saying, we can take care of this pretty easily in the cath lab. Unfortunately, for Huey and for the patient, she'd had a mechanical valve placed in the pulmonary valve position, and to make matters worse, that valve wasn't working very well. One of the leaflets was stuck open. This is actually a picture of her explanted pulmonary valve that shows some organized thrombus and pannus, rendering that valve not very well functional. This is an intraoperative picture of this woman. Her head is up here, her feet are down there. That's her left side, this is her right side. And what I did was I divided her ascending aortic graft. I resected her branch pulmonary arteries and replacement from pericardium to pericardium and reconstructed those with a Gore-Tex graft. I then took a valved conduit and sewed that to that reconstructed branch pulmonary artery, and then reimplanted that onto the right ventricular outflow tract. And she did very well. She went home in 6 days. In addition to tetralogy of Fallot, which again is one of the most common lesions that babies are born with cyanosis, transposition of the great arteries, which we heard about a little bit today too. Another lesion in patients who have really had a number of different surgical treatments over the last 50 years. And just to refresh everybody's memory, transposition of the great arteries, the most common is from the right ventricle, the aorta originates, and from the left ventricle, the pulmonary artery originates. Cyanotic lesion, babies are born blue, and essentially what you have is the desaturated blood returning to the heart, going into the right ventricle, back out into the systemic circulation. The blood returning from the lungs, the oxygenated blood, coming into the left ventricle, out the pulmonary artery, and back to the lungs. So you essentially have two circuits of blood that aren't really working in series. The sending operation was developed in the mid to late 50s, and I would say even by today's standards, this is a really elegant, intricate, and technically complicated operation. And we use these terms all the time, and in this generation, there are a lot of people who really don't understand what those are. What's old is new again. Pediatric heart surgeons are starting to do sending operations again for double switch operations, but there's a whole generation that didn't really have an appreciation for that. And what a sending operation is an atrial switch procedure in which you open up the right atrium, you mobilize the atrial septum, and you create a flap that you rotate back into the left ventricle and isolate the pulmonary arteries. And then you make an incision in the left atrial side, rotate the right atrial flap over so that you create a tunnel so that all the blood coming from the superior and inferior vena cava go across this rotational flap to what was previously the left atrium and into the systemic left ventricle, and it gets directed out the pulmonary artery. And then you rotate the right atrium back over the top of that tunnel so that now all of the pulmonary venous blood that was now isolated by your rotational flap comes out and goes across into the right ventricle and out the aorta. This is really a palliative operation. Even though you reconstruct the anatomy, you reconstruct it in a physiologic rather than an anatomic way. A few years later, Dr. Mustard up in Canada developed another, I would say, a simpler operation. Just as a point of historic interest, Mustard, by training, was an orthopedic surgeon. The initial Mustard operation was an orthopedic operation to treat patients afflicted with polio. So the real purists would say this is the Mustard cardiovascular operation. And what Dr. Mustard did was he used the same principle of baffling the systemic venous return over to the left ventricle, but he did it with a patch. He excised the atrial septum, took a patch, and created a baffle so that the superior vena cava and inferior vena cava blood could be directed over again to the left ventricle to go out the pulmonary artery, and that the now isolated pulmonary veins could come across into the right ventricle and out the aorta. That had given way from around the time of the late 70s to mid 80s to what are done most commonly now is the arterial switch operation. Again, another really elegant, technically complex operation that was, at least when I was in training, was considered to be a corrective or curative operation. The arterial switch operation, the aorta and pulmonary artery are divided just at their sinotubular junctions. You mobilize the coronary arteries off of the aortic root. You perform what's called the Lecomte maneuver. The pulmonary artery is usually behind the ascending aorta. In the Lecomte maneuver, you move the pulmonary artery anterior or to the aorta, and you have to mobilize the pulmonary arteries pretty extensively in order to be able to do that. Then the coronary artery buttons are then attached to what was previously the pulmonary root, attach the pulmonary artery, now posterior, you attach the aorta to what was previously the pulmonary root, and then attach the branch pulmonary arteries to the reconstructed pulmonary root. Great operation, again, considered to be a total correction. At least that's what we thought, kind of like what we thought with tetralogy of Fallot. This is a report out of Germany where they looked at their history over time and their evolution from, they did actually mustards first, and then Sennings in the white, and then the arterial switch operations in the black. And if you look at their long-term survival, it's actually quite good. Arterial switch doing the best in terms of long-term survival. But if you look at freedom from reoperation, you would think, certainly for a curative operation, that we would do better than that. That the number of patients with both atrial and arterial switch operations do have an increased risk of needing further procedures. It was well known even in kids, and probably due to the technical aspects of mobilizing the pulmonary arteries, that you could get a stenosis of the pulmonary arteries, and pretty straightforward technical operation to patch and enlarge that. Another problem has been the development of coronary artery stenosis, probably related again to those arteries being placed under tension or traction. And a coronary artery bypass operation in a child or even in a teenager is more of a challenge to do. So there are procedures that we have to try to, not unlike the unroofing procedures for anomalous coronary arteries, to reconstruct, or certainly in the adult, if there are coronary problems, we can bypass them. What is still an unsolved but concerning problem is the fate of the new aortic root. We'll come to appreciate that a lot of these kids and now teenagers and young adults, these aortic roots seem to dilate. They become aneurysms in many of these patients. So far, the rate that they develop aortic regurgitation at the moderate or severe level is not that bad yet, but the rate of aneurysmal degeneration is quite concerning. And this is, again, the arterial switch operation is done in the infant. So we're talking about 16, 18 years. Many of the pediatric heart surgeons are watching these patients, but I do think that it's pretty soon going to become an issue. Not so long ago, if you had aortic root problems, you had to throw the whole thing away, including the valve, and replace it. We've had some excellent experience over the last decade with valve-sparing aortic root operations. It's a great operation, and the durability of it, at least 10 to 15 years out, seems to be quite good. In general, not necessarily for this indication. In patients who have had arterial switch operations, it can be a challenge because the pulmonary artery is in the way. You have to move the pulmonary artery out of the way, usually by transecting it, and taking out the neo-aortic root tissue, mobilizing the coronary arteries, reimplanting the aortic valve inside a graft, reattaching the coronary arteries back onto it. And as I said, this works out pretty well. In patients who have had atrial switch operations, whether it's the sunning or the mustard, that palliation has resulted in the right ventricle, the morphologic right ventricle, being the systemic pumping chamber. We talk about the right and the left ventricle just like it's on the right or the left side. As you all know, the morphology and the function of the right ventricle is different from that of the left ventricle. And there is increasing concern of the fate of that right ventricle that is used to be the systemic pumping chamber. And if you look at over the long term, patients who have had atrial switch operations, and a less common group of patients who have had who were born with corrected transposition, congenitally corrected transposition of the great arteries, that the incidence of systemic ventricular failure is concerning. Certainly in patients with congenitally corrected transposition, that right ventricle, the coronary arteries are oftentimes inverted, that the right coronary artery and certainly the microvascular circulation may not be up to snuff in providing the circulation for the power that is needed to be generated by that, and that unlike our assessment of left ventricular failure, our assessment of systemic right ventricular failure is not as good. And even patients who have ejection fractions of in the mid-40s or less have a very concerning problem. And certainly from a surgical point of view, many of the things that we can do in the systemic left ventricle does not seem to work out as well. And I'm just going to go through this pretty quickly. The palliated lesions, we talked about different kinds of shunts. This is a modified Blalock-Taussig shunt. Unlike the one designed by Vivian Thomas, a modified Blalock-Taussig shunt is actually a prosthetic that is anastomosed from the innominate or subclavian artery to the pulmonary artery, and that doesn't grow unlike the normal the native subclavian artery. This does put an increased workload on the whatever ventricle is, whether it's a right or a left ventricle, has to do twice the work. The bidirectional Glenn shunt, anastomosis of the divided superior vena cava to the pulmonary artery, and certainly in a baby or a child, that redirects about 50% of the blood flow to the pulmonary circulation, bypassing the ventricle. Dr. Montero talked about the different kinds of Fontan procedures there are. And when somebody says they've had a Fontan, to me that's like saying somebody's had chemotherapy for cancer. It doesn't really tell you very much, other than it puts it into a category of operations. The classic Fontan, the right atrium, by any number of configurations, is sewn to the pulmonary artery, leaving that right atrium, as I think Tom talked about earlier. That atrium is allowed to grow, get bigger. The flow through that right atrium is very energy inefficient. There are eddy currents that develop. There's clot that forms in it. The lateral tunnel, which is a piece of prosthetic patch usually, is sewn inside the right atrium, and you create a tunnel within the atrium. And that certainly has decreased the size at which the native right atrium can grow, but not to the same degree as an extracardiac conduit, and that is a disconnection of the inferior vena cava, and a graft is sewn from the inferior vena cava directly to the pulmonary artery. Like many of the challenges of doing surgery in a child, what fits as a child doesn't necessarily isn't the same fit when we get to be older and adult. So the size graft that you use in a child may not be the appropriate size as they get older. We already heard a lot about the fate of Fontans. Suffice it to say that there are challenges associated with it. The ideal circulation, the ideal solution to a heart that's not working really well is to cut it out. It's a basic surgical solution. If it doesn't work, cut it out and replace it or fix it. We heard there are a lot of issues associated with transplantation as a solution for congenital heart disease. not the least of which are there are not enough hearts. Over the last 20 years, the number of heart transplants have not significantly increased, really. It's about a little over 2,000 a year, and that hasn't changed. What has changed, as we heard about, is mechanical circulatory support options. That has supported patients very effectively. What's good about that is also what's bad about it. There are now more patients waiting for heart transplants. And so that transplant list continues to go up. The number of transplants continues to stay the same. And one of the things I need to do in terms of updating my slides are the results for heart transplant for congenital heart disease. We talked about that, so we don't need to talk about that anymore. There are some options in patients who have had Fontans that have had certainly previous iterations of the Fontan operation. We can do Fontan conversions, which involves doing arrhythmia surgery on them and reconstructing them to have a total cavo-pulmonary connection, to essentially do extracardiac conduits, decrease the size of their atrium, do arrhythmia surgery with the expectation, or at least the hope, that that will change the outcomes. We already heard a little bit about the increasing role of mechanical circulatory support. That's a real growth area in heart surgery. The pumps are getting smaller, they're getting better, they're getting more durable. Just 2 weeks ago, I had a patient who up until 2 weeks ago was the longest living patient with a LVAD. She lived 11 years, and she just passed away 2 weeks ago. There have been some, from a surgical point of view, there are, in patients who have congenital heart disease, there are some things that you have to do to get the commercially available pumps to fit, but it's a very exciting time in the development of these devices. Again, acquired heart disease, in addition to congenital heart disease, that's more news to follow. That is the sleeping giant. That is going to be something that we're all going to have to figure out and how to take care of those patients, and I think it will be a number of challenges. So in summary, as we heard, there are more adults now than children with congenital heart disease. The solutions, the surgical solutions that have helped in the past have now created new challenges in the future. I don't think it's been said today, but it should be. Adults with congenital heart disease are not just big children. They have different issues and different challenges. And certainly some of the surgical solutions that have worked so well in children don't seem to work as well in adults. And we need to work through that and make improvements on that. No doubt the best way to take care of these patients, these people, are through a team approach with a group of dedicated professionals using innovative multidisciplinary collaboration to help manage these patients and to get them through the next part of their lives. And with that, I'll stop. I'm happy to answer any questions.